Hi, good morning. I think I won the debate already. So what I'll do is over the next few minutes give you an overview of how we think that antiplatelets in the dual form can be for a shorter duration, and what is the basis for saying so. We are all aware that dual antiplatelets are at this time recommended in all guidelines for a year, at least for 12 months or for 6 to 12 months after a drug-eluting stent implantation, according to ACC ESC guidelines. This is based on late stent thrombosis or very late stent thrombosis, and is actually consensus based, and this was in the earlier based on the earlier or Cipher or Taxus data, or what we could say the stage 1 drug-eluting stents or phase 1 drug-eluting stents. This scene has changed. We know that as Dr. Sandeep Mishra showed, dual antiplatelets is necessary because you want to achieve antiplatelet action, and because we know antiplatelet action is dependent at multiple sites, so we need aspirin and another agent based on the CREDO trial. But when you do prolonged dual antiplatelet, there is incidence of major and minor bleeds, which get worse off with time. And so you have to have a time where you get the benefit of preventing ischemic events and you avoid the bleeding risk. Some of the real world challenges is that 1 in every 6 patients who receives stent needs to interrupt or may interrupt dual antiplatelets within 12 months. And the data is based on real world data that about 60% of patients interrupt dual antiplatelets permanently. And this is what Windekar presented in EuroPCR of this year. If you look at the clinical reasons, it's about 18.3 patient-related reasons, and sometimes it's not available. So the reasons for temporary or permanent discontinuation, temporary usually a procedure like if you have a cataract surgery or other reasons, you need to have temporary interruption, while a permanent interruption is also related to clinical events or other reasons. What is the backup data? If you look at the Xience dual antiplatelet data from all the series, you have a large 14,000 base data. You have a 3-month interruption data. You have a 1-month interruption data from these series. And if you look at 0 to 3 month dual antiplatelet interruption with Xience, the thrombosis is 1.6% in 0 to 3 months, but in 3 to 12 months, the thrombosis is 0%. So 0% stent thrombosis rates after dual antiplatelet interruption from 3 to 2 months is available from the Xience V real world patients. And timing of first dual antiplatelet interruption also 0 to 1 month you have a higher incidence, but 1 to 12 months the thrombosis is not significant. Dual antiplatelet stent thrombosis with permanent dual antiplatelet discontinuation in 6 to 24 months. So if you do permanent dual antiplatelet discontinuation, after 6 months in the Zion's data, then you have a thrombosis which is not higher than no dual antiplatelet discontinued. This is also available from pooled data from SPIRIT 2 and compared trials, where after 6 months dual antiplatelet therapy stoppage was not averse with more thrombosis. So what do we have for the Endeavour or the Resolute International Data Registry? These are patients who were followed up in various series, and you look at the timing of first dual antiplatelet interruption through 1 year. First interruption 0 to 3 months, first interruption 3 to 12 months, 0% even if dual antiplatelet was interrupted. Similarly, you have timing of DAPT 0 to 1 month and 1 to 12 months. Even 1 to 12 months, the dual antiplatelet interruption did not produce adverse events. This is also the pool data showing that 1 month later in the other trials you did not have any adverse problems. Because of this, many trials have been done, some registry, some small trials. This is from a Korean center where about 180 patients were taken up in this RESET trial, and dual antiplatelet therapy was tested for 3 months following Endeavour Zotalimus eluting stent, and there was no difference in the endpoints in patients who were given 3-month dual antiplatelet versus standard therapy. And there is then a registry also from the same Seoul Korea group, which is looking at, which did not suggest any uptick in adverse clinical events with stopping clopidogrel just 3 months after Endeavour Zotalimus eluting Medtronic stent. There is also a possibility of a large trial on 20,000 patients, which is going to be termed the dual antiplatelet therapy trial, and in which rather than 12 or 30 month dual antiplatelet, Medtronic was holding to a 6-month dual antiplatelet therapy arm in the trial. There is also an investigative trial which is published both in Circulation and also as a clinical research in European Society of about 2,000 patients who received bare metal, ZES, paclitaxel eluting stent and everolimus stents. So 4 arms, and if you look at the death MICVA in the arms, you find that even with the Endeavour Resolute, is the only 6-month dual antiplatelet therapy was in fact better than the 24-month. This study, called the Prodigy study, shows that optimal duration of dual antiplatelet may be stent specific and does not support a clear association between stent potency and vulnerability to shorter dual antiplatelet. We know that the Endeavour Sprint had a higher in-stent late lumen loss. There's also an excellent trial on about 700 patients each, in which you had an everolimus stent and a sirolimus stent or the cipher, and if you had the 12-month was favored in this trial in the sirolimus eluting stent, while a 6-month dual antiplatelet was adequate for the everolimus. This has been updated as a CAE mark on the packing and is available in the US as a Resolute, where it said the CE mark in Europe has allowed a 3-month only dual antiplatelet duration after Xience Prime or Xience V, and also the Resolute. Also, the PROMIS element has also been given a CE mark for 3-month dual antiplatelet labeling based on its data in the Platinum WH trial, where 0 to 3 month interrupted did not have a higher thrombosis. We now know, of course, that it's not all stents are not same. They have different stent thickness. They have different baseline element like cobalt or stainless steel. Their thickness could vary. Their polymers vary, and all this makes every stent a different animal. But if you look at the guidelines, there is no trial data to most of the guidelines as of now still endorse a 12-month drug-eluting stent for non-ACS indication, and it's only in the bare metal where 1 month is allowed and up to 12 months unless patient is at bleeding risk. You do have future trials like the ZS study where that Zotalimus eluting stent versus the bare metal will be tested at high thrombotic or bleeding or low stenosis risk patients, allowing for only 1 month dual antiplatelet in both stent arms because patients may not be able to tolerate longer duration of therapy. This is ongoing. Also exciting is the comparative effectiveness of 1 month of ticagrelor plus aspirin followed by ticagrelor monotherapy versus the current day intensive dual antiplatelet in all comers undergoing PCI with unrestricted Biolimus A9 eluting stent called the global leaders. So this may pave way for monotherapy in the coming years. So just to conclude, ladies and gentlemen, I'd like to say that all stent platforms have different vessel healing, different anti-proliferative properties, device-specific characteristics like the type of stent, patient characteristics, whether it's acute coronary syndrome or chronic CAD, maybe potential determinants of duration of dual antiplatelets. And so also the complexity of lesion, whether it's a left main or a bifurcation or multiple long stents. Short-term dual antiplatelets provide similar efficacy with less adverse events, especially in the newer stents. CE mark for 3 months dual antiplatelet has been put on the label for all the current second generation stents like the Endeavor, the Xience and the PROMIS element. Of course, we look forward to ongoing drug-eluting stents aimed at unraveling the optimal dual antiplatelet therapy, whether the stronger and more effective drugs like ticagrelor or prasugrel may be effective as monotherapy or for a shorter time, 1 month dual antiplatelet and then monotherapy in the long run. Thank you for your kind attention.